like to invite the real Shalini Mohan to give the talk on evaluating the ocular surface. Shalini.
Thank you so much, respected chair, and good morning, everyone. So today I will be talking about ocular surface evaluation in glaucoma patients. Can I have my presentation?
It's not visible. Dr. Shalini Mohan.
Dr. Medha, come to the dais only one minute before, actually. Otherwise, you'll have to stand up for a long time. So
They don't know the timer. The timer is not visible to all. Audio visual. Do you have a buzzer or anything? Yeah. So 1 minute before the 7 minutes this thing, just give a one single buzz. So the speakers will know that 1 minute is left. We can come on the dais.
और अगर तुम में से एक यहाँ रहेगा ना बहुत अच्छा होगा क्योंकि ये बार-बार कल भी ऐसे ही हो रहा था कि चालू नहीं हो रहा था presentation. You be here so that you coordinating properly.
Yes,
Yeah, thank you. So we understand that major concern with anti-glaucoma therapy is ocular surface damage, which is seen in 45 to 60% of patients which are on anti-glaucoma medication, which can be due to the primary drug or due to the preservative. It leads to poor medication compliance and also failure of anti-glaucoma surgery, which might be subconjunctival. So how can we assess ocular surface in our patients? It can be subjective by various questionnaires which are available, or it can be objective by variety of these tests which I will be discussing. So OSDI scoring is very commonly used, which is 12-item questionnaire, and it is ranged from 0 to 4, and then patient has to answer these questions. And after this, it is multiplied by 12.5 and the sum of individual question scores divided by number of the questions which patient has answered is yielding a score from 0 to 100. So 0 being normal and 100 being the severe form of the dry eye. There are variety of simplified questionnaires also available which can be used to assess the subjective ocular surface diseases. When we talk about objective, the most important is tear film breakup time and very easily available to us also during slit lamp examination. So it is the time of appearance of first random black spot onto the surface of cornea. It is important that cornea must not involve an area of altered cornea, and we should look from limbus to limbus, and we need to take at least 3 readings, average it, and if it is less than 5 seconds, then it is definitely abnormal. So there can be a variety of patterns seen on TBUT. Fluorescein staining, which is used for TBUT, is also very important for assessment of integrity of cornea and conjunctival epithelium. It can also assess the volume of the tear film by measuring the meniscus height. But important thing is we should not use lubricant eye drops while doing this test because this may alter the result. Now, I find this Asia Dry Eye Workshop Society parameters very useful. In conventional method, we use blue filter, but because the blue light is reflected very highly from the surface of sclera, so it can give good assessment of corneal problems, but not good assessment of conjunctival problem. Therefore, with blue-free filter, barrel filter, we can see the conjunctival issues also, and therefore, we should try to use this. Now, this is a very important chart which I am showing. It actually helps us to classify which type of dry eye is there in the patient of glaucoma, and then accordingly you can treat. The first column you can see is of aqueous deficient dry eye, and the first picture you're seeing, it has very areas of break. If after the first blink you can see these areas of break, then it is definitely aqueous deficient severe form of dry eye. Whereas if you can see a line break which is visible in the lower photograph, then this is actually a kind of mild to moderate aqueous deficient dry eye. So you need to add on lubricants as per the patient need. The second column you are seeing is the mucin deficient dry eye. Here you can see these are the small spots visible into the area. These spot break are actually classic of poor wettability of the cornea, and in the inferior photograph you can see there is a dimple break. These are the vertical lines which are visible, which signify mild to moderate dry eye. Whenever there is problem with the lipid layer, it is increased evaporation, and then you can find random areas onto the surface of cornea, and therefore you can decide what is the type of dry eye in your patient. It also helps to delineate the various type of corneal pattern, and you can actually grade them depending on the dots you see onto the examination. The first picture you can see none. In the grade 2 is where you can see 1 to 15 dots. In grade 2, you can see 16 to 30, and if they are more than 30, it is grade 3. So depending on severity, you can increase the intensity of your treatment. Non-invasive breakup time is definitely better, which actually projects the rings onto the surface of cornea, but you need specialized machines for this. Tear volume assessment can be done by tear meniscus height, where you classify normal, reduced, or excessive, or you can do Schirmer's test, where you can see take up the Schirmer's strip, and if it is more than 15 millimeter, it is normal. If it is less than 5 millimeter, it is aqueous deficient. Try to keep the Schirmer's strip at the junction of lateral third and the medial third. So tear meniscus height can also be assessed on anterior segment OCT or by taking photographs, or you can see this strip, which is used for meniscometry, but we don't use that commonly in our glaucoma clinic. So fluorescein is the best thing to be available to us. Now, this is the lip cough, which is the conjunctival fold due to the rubbing of the eyelids onto the due to the friction, and the number and the severity helps us to delineate the severity of the dry eyes. Now, lipid layer assessment is important. You can express with the help of COB evaluator, or you can pinch to see how much is the sebum. Otherwise, you can do meibomography by infrared photography. Tear film osmolarity is important component which helps us to assess the inflammation, but that needs specialized instrument. So to summarize, I will say that evaluation of ocular surface is important for our glaucoma patients. We just not need to diagnose, but we also need to assess what is the type and what is the severity. And therefore, early recognition is important so that we can apply timely treatment which can improve the quality of life of our patient and improve the medication adherence. Thank you so much for your kind attention.
Thank you, Dr. Shalini, for a wonderful talk. This is something we often miss during our examinations, and this is a must for glaucoma.